Good afternoon, everyone, and we welcome you to our session entitled Hot Topics in Heart Failure. We are incredibly honored to have with us today our international speakers and good colleagues and friends. And please let me introduce my co-chairs for this session. It's Yuri Mariev and Anastasia Щендрыгина and Yasmin Rustamova, who is a cardiologist from Azerbaijan, but she will join us a bit later. And our first speaker will be Nikolai Novitsky, a cardiologist from Kaluga, who will talk about epidemiology of heart failure and universal definition of heart failure. Nikolai, please, floor is yours.
Видно нормально?
Да.
Okay. Hello and welcome, dear friends. It's a great honor to participate in this symposium, and big thanks for our chairs. Of course, big thanks for Russian Cardiology Society and our leader, Irina Ляпина, for these organizations, and of course, our foreign friends, our Twitter friends, to support our Russian Congress of Young Cardiologists. And I'll begin. I'm from Kaluga State University and City Hospital. And title of my presentation is New Definition, Stages, and some about epidemiology of heart failure. This is my conflict of interest. And my presentation will be based on two documents. It's universal definition of heart failure and new guidelines of American College of Cardiology, fresh guidelines. And if we examine what kind of definition and classifications were included in academic guidelines and scientific documents, we usually three categories. First one is overarching definition of syndrome of heart failure, which is quite important for diagnosis, for practice in trials, and in enrollment and research. Second is classifications of ejection fraction, which is important for defining categories to target guideline therapies. And third of classifications is stages. It's important for prognostications and also to emphasis prevention. And we're starting with the definition of the syndrome. The traditional textbook defined heart failure is a clinical syndrome caused by inability of the heart to supply blood to meet metabolic demands of the body. But the definition of inability to meet the metabolic demands is not applicable to most patients. As shown in this slide, study of stage D heart failure patients who underwent right catheterizations, lactate levels were measured as a modification of tissue level impairment. And we found to be normal in 75% of patients with advanced heart failure. Tissue level hypoxia in inability to meet metabolic demands may be a terminal manifestation. It may be not applicable to the general population with heart failure. In this slide, you will see definition of heart failure in Russian and TAC guidelines, and often they significantly differ from textbook definition and focus on syndrome with specific symptoms and signs, and also on the symptoms being attributable to abnormality hemodynamic features such as reduced cardiac output and elevated finding pressures. These definitions of in fresh guidelines, AHA and ACC classifications, American guidelines, and some the same with our, but some the same with European guidelines. But the definition, there are a new definition, new universal definition of heart failure, and it incorporates not only symptoms or signs, but also objective markers. And summarizes heart failure is a clinical syndrome with current or prior symptoms and signs caused by structural and functional cardiac abnormality, and corroborated with at least one of the following: elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systematic congestions by diagnostic modalities such as imaging or hemodynamic measurements at rest or with provocation. second chapter of my presentations. It's classifications by EF. We have heart failure with reduced ejection fraction, EF less or equal 40%. Heart failure with mildly reduced ejection fraction, EF 41 or 49. Heart failure with preserved ejection fraction, its EF is more or equal 50%, and new heart failure with improved EF, which is baseline EF maybe less 40% and more than 10% from baseline and second measurement. The same classifications in American guidelines you will see on this slide. The reason to standardization EF categories was expanding life-saving therapies from HF with reduced EF to heart failure with mildly reduced ejection fraction, and expanding in indication for ARNI from FDA subsequent to the post-hoc analysis that demonstrating benefit in patients with EF less 57%. Third chapter of definition of heart failure is stages. There are stages of heart failure in a new universal definition of heart failure. We will see stage A at risk for heart failure, patients at risk, but without current or prior symptoms and or signs of HF. These patients with hypertension, CVD, diabetes mellitus, who at risk. Second stage is stage B, pre-heart failure, patients without current or prior signs, but evidence of one of the following: it is structural heart disease, maybe abnormal cardiac function, and maybe elevated natriuretic peptide levels or elevated troponin, especially in patients with cardiotoxic agents. For example, it's oncologist patients. Stage C, heart failure, it's a classic patient with current or prior symptoms, signs of heart failure caused by structural or functional cardiac abnormality. And heart failure in remission and persistent heart failure. In stage D, advanced heart failure, several symptoms and signs of heart failure and rest, recurrent hospitalizations despite guidelines-directed medical therapy. But some patients can improve from stage D to stage C. The same stage in American guidelines you will see in this slide. And positional paper experts also focus on terminologies for clinical trajectory as emphasis to use persistent heart failure with, rather than stable for those patients with symptoms that may not be showing active signs or worsening, or heart failure in remission rather than recovered heart failure for those patients with resolution of symptoms or signs of heart failure or with resolution of previous structural and functional heart disease after a phase of symptomatic heart failure. It's supported by the result of the randomized TREAD-HF trial, which demonstrate that withdrawal of pharmacological heart failure therapy from patients with dilated cardiomyopathy recovered with heart failure results in 40 cases, suggesting improvement of function represent remission rather permanent recovery for many patients. Some same in American guidance, but without improved HF. It was in universal definition of heart failure. And a little bit of epidemiology. It's in this slide shows the prevalence of heart failure worldwide. We see that, for example, in Germany, the prevalence of heart failure 4%. While in other countries it's 1, 2, more 3, although in populations in Europe very similar. We need to standardize single definitions, single coding for chronic heart failure, and I hope that new document, a universal definition of heart failure, will help to standardize approach to epidemiology and treatment in our country and countries worldwide. And summary my presentations, standardization of heart failure syndrome in definition to enhance appropriate diagnosis and optimization guidelines direct medical therapy and to achieve uniformity of care. New revised classification of heart failure to clarify treatment indication for pre-HF and as well in heart failure. EF classifications in phases for improved, not recovered ejection fraction, and a new trajectories, heart failure in remission, and heart failure, persistent heart failure. Thank you for attention, and I will all of us invite to our city, Kaluga city. Thank you very much.
Thank you very much, Nikolai. Maybe just a short question before we move on to our next speaker. Why it is important to not use the terminology of stable heart failure?
Thank you very much for question. I think our patients with heart failure not stable because we know that when we diagnose this disease, 50% patients will death in 30 days, and we emphasize all of us. We emphasize all therapy, all care to improve patients and to therapy guidelines therapy. And I think patients may often recurrent hospitalizations, and these patients will not on не знаю, как по-английски диспансерного наблюдения, no dispensarization in all patients.
So just do not think that even without clinical symptoms, patient is stable and still there is very high risk of negative outcomes. So
Yes.
okay, and we probably move to our next speaker, who is cardiologist, fellow of American College of Cardiology, Хан Нуанг Тан, from USA, Vermont. Henry, please.
Everyone, I'm Naung Tun from UV Medical Center, London College of Medicine, University of Vermont, Belgium. Today I'm gonna just talk to you about the coronary artery disease in heart failure, and what we have learned and what is the horizon. So first of all, I would like to thank you for inviting me to this Young Cardiology Forum meeting. I have nothing to declare. So many patients, we do coronary angiogram. It's time for PCN, so we do angiogram easily at many heart centers. Remarkably, in 2022, we have months of evidence. So what to do, how to do, what not to do when we consider about PCIs. And when we talk about the CABG, its pros and cons, in regards to CABG, you might think bypass surgery is good, some may argue it's not good. Actually, it takes intensive care and we need a sternotomy. So what is the balance? What is the pros and cons? So if we consider the CABG, we may gain the improved LV function, or we may gain the less ischemia, or the risk of the MIs is decreased, and also reduce the mortality. So that the advantages of the bypass surgery is it is actually a major surgery. And in that is the surgical trauma to the patient and a cap, if you will, one that it will take a few weeks to recover from. So these are the pros and cons, so we have to figure out before we do it. A CAS trial is this an old trial, so it's not actually a heart failure trial. It was not an answer for this question. When I was in internship life, I remember I was told by my old professor about this trial. And it's a very old trial. It was published in NEJM in 1984. So when we talk about the CABG in a coronary artery disease in a patient with ischemic cardiomyopathy, this is a stage trial. Some people like this trial, some people don't like it, but insightfully we gain this important information from stakes. So in this study, in the stakes, so you see here the state exclude a patient with the ejection fraction of the 35% or less, or with a coronary artery disease which amendment to CABG were randomly assigned to medical therapy alone, or medical therapy with cabbage, but still excluded, you see, like main coronary artery disease and angina, class 3 and greater. So here we see in this mortality benefits, the primary outcome for 5 years, that is significant. There's significantly no difference. So basically, there is not different benefit at all in 2 years. Again, you see it is a positive or negative trial after 10 years. The rate of death from any cause, the death from cardiovascular cause, and the death from any cause or hospitalization for cardiovascular cause was significantly lower over 10 years to a man patient. So again, you see it is a crucial analysis on a stake. So age on the benefit and mortality. There's some more sub-study of states, more severe disease and more benefits. So, and interestingly, you see here diabetes finding is interesting. So most bypass surgery trial have diabetes as well in the stake. The patient with or without diabetes received a consistent benefit. And again, interestingly, patient with or without angina receive a consistent benefit as well. So when we talk about the intent of the age, although the cabbage benefit in cardiovascular mortality was consistent across all ages, so we noticed in older patient it has less reduction in all-cause mortality. So now we talk about the viability test on the stake. The state is the best data so far. Is this a randomized control trial for which has viability test, but it's not the best evidence for viability. So, but as you see, it's not a perfect trial. So prior to state, there are some observational study and some 2 to 3 meta-analysis show a benefit for viability testing. You know, viability sub-study of state was a non-randomized observational analysis of 50% of the state patients who had viability with SPECT or dovitamin stress echo, but still didn't show the benefits. So as I was saying, we need because we have no useful data on where viability is helpful or not. We need more evidence on that. So again, and so in PCI and heart failure, we all know there are a lot of challenges in PCI for heart failure. So we see many CTO patients, so many bifurcation. We may need LVAD in short or end-stage heart failure. So we need to think which one is benefit from PCI or not. And then, and here is just a great meta-analysis. It shows 6 out of 10 randomized trials exclude the patient with heart failure. So one cabbage compared with a PCR in multiple vessel disease. So you see 3% of the patient with this cabbage had a heart failure. So these are not heart failure trial. When you look at the inclusion criteria in Syntax, the 2% has a LV ejection fraction less than 30%. In Freedom, 2.5% has the LV dysfunction less than 40%. In Barituri trial, 7% had heart failure. So these are not actual answer to give for their heart failure in coronary artery disease. So, and then, so what is the difference? What is the evidence for PCI versus medical therapy? So Courage trial, Courage, if it is a great study and a Lemma trial, but they also excluded heart failure patient with ejection fraction less than 30%. So the short trial is a great trial, but it is actually a STEMI trial. It's not a heart failure trial. Capillary short, again, the capillary short is a people meeting is a heart failure trial. I think actually it's not. Actually, it is a heart attack trial with a short steady patient. In this trial, the participants they had a ventilator resuscitated and a patient had a high platelet level. And we have gained what we have gained so far. So we have strong evidence on cardiogenic shock with AMI and acute coronary syndrome, but we don't have enough data on the cardiogenic shock, not due to the AMI or STEMI. So here again you see these trials also do not apply to acute heart failure. It's also a synthesis trial, Freedom, Barry-2D. These are the important and great trials, but did not give an answer for heart failure or coronary artery disease. So again, here we see in ischemia trial. So recently in ischemia, this trial is a recent. It was conducted in coronary heart failure patient with coronary artery disease, but they excluded left ventricular ejection fraction less than 35%, but it included EF 35 to 45%. So in ischemia, participant with a stable ischemic heart disease and at least a moderate ischemia with a history of heart failure or a ventricular dysfunction with at an increased risk for a primary outcome. In this small high-risk subgroup analysis, you see here with heart failure, so left ventricular ejection fraction 35% to 45%, and initial invasive approach was associated with a better event-free survival rate. Of course, so this is important data. You see here the majority of the patient hospitalized for new onset of heart failure, but did not receive a testing for ischemic coronary artery disease either during hospitalization or within 30 days. So it suggests a significant underutilization of ischemic coronary artery disease assessment in new onset of heart failure patients. So what did the guidelines show? So these are the EACC 2022 and ESC 2021 heart failure guideline. So as you see here, surgical revascularization is class 1A recommendation in ACC 2022 guideline for patients with heart failure and LVEF less than 35% on top of the medical therapy. So when we talk about the revascularization for coronary artery disease in HFpEF, is it still controversial because we don't have enough evidence. So in HFpEF, is this actually is a big basket. So we know it has a variety of phenotypes to amend, and if microvascular disease is a culprit of HFpEF. In that, you see here in this slide, 51% of the HFpEF patient has coronary microvascular dysfunction, so who underwent coronary angiograms had a CAD. So this is a data recently published in JACC. So here's another evidence. Since coronary artery disease is common in patients with HFpEF, as I was saying, and is also associated with increased mortality and greater deterioration in ventricular function. This is a positive study. This study shows revascularization may be associated with the preservation of a cardiac function and improved outcome in patients with coronary artery disease. But this study didn't assess the impact of revascularization on symptoms because there was marked variability in follow-up and duration. Here again, this is a nationwide study that was recently published in the European Journal of Heart Failure. This data supports the safety of CABG in heart failure patients and suggests continuity of mortality risk of ischemic heart failure when stratified by baseline EF before revascularization. And here again, so what we have so far now, so we need a lot of strong evidence when we consider revascularization in heart failure. These are the ongoing or planned randomized trial evaluating in PCI in heart failure patients. This is the CHIP, PCIS3 trial, and PROTECT 4 trial, and REVIVE PCIS2 trial as well amend them. The REVIVE trial, which is one of the most important trial, I think it will give an answer, is a great piece to give us some important answer in this field of the heart failure and PCI. In a state trial, as you see, It includes the chronic heart failure trial. The participant has the ejection fraction less than 35%, and extensive coronary artery disease, and at least 4 segments of valve myocardium. And the heart team doesn't recommend cabbage, so I think and hopefully we'll see the outcome of the trial in upcoming ESC Congress. So I'm really excited to see this outcome from the REVIVE trial. So in conclusion, so think about the investigation of coronary artery disease in heart failure patients. So because we have to figure out before we consider revascularization in across the spectrum of the heart failure patient. If a patient has heart failure and younger, so we could consider cabbage if it's appropriate answer if revascularization is needed. So to date, so far, however, because comparative data to establish the role of PCI when we compare to cabbage in patient in heart failure, we still, as I was saying, we still need a strong evidence. So when we apply in evidence based in our clinical criteria, but a lot of trials ongoing to clarify the role of PCI in heart failure. So last but not least, so don't forget to consider the personalized approach because we see there's a lot of ischemic heart disease patient with ischemic cardiomyopathy as well as a heart failure patient with coronary artery disease. We have so different phenotypes, so we have to consider so patient by patient when we think so revascularization. So thank you very much for your attention. I really appreciate for inviting me to this conference. Thank you.
May I interrupt you, Yuri, because we cannot hear you. I think technical support team could help us with that. Turning on the unmute, please, Yuri Maria.
Of course, there is a joke that yes, there is a joke that mute and unmute is the most common mistake nowadays, but it wasn't my mistake at this moment because I'm here on stage, not or near my computer. This was a nice talk, but we will go further and we will discuss this talk in the end. And the next speaker will be Щендрыгина Anastasia Alexandrovna from Moscow, and her talk was about COVID-19 and heart failure.
So let me share my screen. Hope you can hear me well. Good afternoon. Thank you very much for your kind introduction. It's a great pleasure for me to be here. And I'm going to speak about COVID-19 and prospective heart failure burden. Here my conflict of interest. And let me first start with epidemiology. For more than 2 years already, we have been living in a situation of global COVID pandemic, with more than 500 million cumulative cases identified and more than 6 million deaths recorded. It was recognized early on that acute COVID is associated with prominent activation of pro-inflammatory system, which may result in developing of acute respiratory distress syndrome and systematic inflammatory response, leading to multi-organ dysfunction, including the heart. The cases of cardiovascular manifestation and complication of acute COVID-19 has been extensively reported, which included acute coronary syndrome, myocarditis, Takotsubo cardiomyopathy, thromboembolic events, and arrhythmias. Of note, new onset of heart failure in hospitalized patients was rather low at about 0.6%. Autopsy studies help us to identify the mechanism of acute cardiac involvement in COVID patients, which include direct damage of endothelial cells mostly, and indirect injury from hypercoagulability state, hypoxia, and cytokine storm. We are aware that many of these risk pathways may also accelerate the trajectory of cardiovascular disease. But it remains to be clarified as to whether COVID-19 may contribute to an increase of heart failure burden in the long term. From the sepsis studies, for example, we know that sepsis survivors had an increased risk of cardiovascular outcomes within 5 years, including congestive heart failure. In a very recent large cohort study just published in Nature Medicine, for the first time, it has been shown that COVID patients exhibit increased risks and 12 months burden of pre-specified cardiovascular outcomes, with the highest incidence for the heart failure, especially for those who were hospitalized. So we could stop actually here, as we have got an answer to our question that heart failure risk is increased in those who recovered from COVID-19. However, this risk represents a critical area for potential intervention to improve post-COVID outcomes. But how to identify those who are at risk? Doubtless that cardiomyocytes damage can lead to residual structural and functional impact on myocardium. That was confirmed by echo data from cross-sectional studies in acute COVID patients, which showed deterioration of both right and left ventricular function in up to 40% of patients on index hospitalization. Additionally, this dysfunction was associated with in-hospital mortality. Most important that the follow-up studies on hospitalized patients, the number of which, however, is limited, but this study demonstrated that left ventricular systolic dysfunction assessed by global longitudinal strain persists within 3 months after hospitalization, while the right ventricular function mostly recovered following COVID-19 resolution. Numerous CMR studies, which were mostly performed within 5 months after COVID-19 diagnosis, also revealed myocardial abnormalities, including non-ischemic LGE and elevated native T1 and T2 time, which were consistent with myocardial edema, myocarditis, or pericarditis. And upon these findings, together with the recognition of post-COVID cardiac symptoms and the novel presence of autoimmune antibodies, the possibility of post-COVID chronic inflammatory cardiac involvement is discussed. In the end, can we consider these residual cardiac abnormalities as imaging biomarkers of future heart failure? We are aware of prognostic significance of asymptomatic left ventricular dysfunction. The data of meta-analysis assessing a total of 25,000 participants with asymptomatic LV dysfunction showed that both systolic and diastolic LV dysfunction were associated with substantial risk for incident heart failure. According to recently updated American heart failure guidelines, the phase of clinically asymptomatic structural and functional cardiac abnormalities considered as pre-heart failure. These abnormalities includes the following signs of structural heart disease as reduced left or right ventricular systolic function, ventricular hypertrophy, chamber enlargement, wall motion abnormalities, or valvular heart disease, as well as the evidence of increased filling pressures. But can we consider residual myocardial changes in COVID survivals as pre-HF? Probably we could, but for now we need more data on cardiac recovery over the time. Today, expert consensus on cardiovascular sequelae of COVID-19 from American College of Cardiology recommends to perform cardiovascular testing in those COVID-recovered patients who exhibit persistent cardiac symptoms. Another question may rise is to whether cardioprotection is needed for COVID-recovered patients. And ACC consensus suggests to consider beta blockers along with RAS inhibitors in those with mildly reduced LV systolic function and stable hemodynamics. Obviously, we're still in need of further studies in this area. So we still have more questions than answers, but in conclusion, I would like to leave you with the following take-home messages. COVID-19 survivors, mostly those who are hospitalized, are at risk of developing heart failure in long-term perspective. If long COVID cardiac symptoms are present, further examination should be considered. Residual myocardial abnormalities detectable in some proportion of COVID survivals, but their prognostic significance requires further investigation. However, these abnormalities may help to identify those who require closer follow-up. And importantly, that we may consider beta blockers or RAS inhibitors in those with mildly reduced ejection fraction. However, further studies on cardioprotections are needed in this area. Thank you very much for your attention, and I will be happy to answer the questions you may have.
I have a question. If we would there were some studies where for example, some athletes who got COVID, after COVID, the MRI was made. And in a lot of these, not in substantial percent, something like in 1-2% of these people, MRI finding, some MRI finding was found. But at the same time, as it was elite athletes, they made repeat MRI, and in many of these people, MRI findings disappeared. So do you think that MRI really, in patients without symptoms, of course, in patients without, so the patient got COVID, then she survived, everything's okay, and there's no new symptoms. Do you think if this patient MRI helped to find something, or we will see just some finding which is not clinically meaningful?
Thank you very much for the very important question. Actually, recently it has been a lot of discussion on this issue because we had a lot of discrepancies among CMR studies, which were due to different patient population and different sequences used. But regarding to your questions, if we focused mostly on those who are young and those who are asymptomatic, basically we don't need to screen them with CMR routinely, only in case if they have any cardiac symptoms post-COVID, but in this case, we should start with conventional cardiovascular testing like ACG, echo, and troponin, and only in case if we see any abnormalities, we can proceed further and perform CMR.
Okay, thank you.
Maybe if I may ask you another question.
Sure.
We know that our government promoted more deeper examination of patients recovered from COVID-19 called углубленная диспансеризация. And during this investigation, the patient could underwent some more detailed examinations, such as additional blood tests, some additional imaging, such as CT scan or echocardiography. What may be clinical signs, symptoms, or laboratory markers you would additionally recommend to those list of tests, which already in our guidelines of Ministry of Health? Maybe specific echocardiography changes, maybe NT-proBNP, which have been discussed recently in our another session.
Thank you for your questions. Actually, first of all, I would like also to emphasize that actually it's very important or mostly focus on those who has prior cardiovascular disease, because those patients are mostly at risk to developing heart failure, and also those who initially on index presentation had elevated cardiac biomarkers as troponin and NT-proBNP, because what we see from imaging studies that those patients mostly have residual myocardial injury. But regarding the specific testing, so basically, of course, I would start with echo and ACG and conventional cardiovascular biomarkers. But what I would add maybe speckle tracking of left ventricle, because we see that it is very sensitive imaging marker of residual left ventricular systolic dysfunction. So otherwise, I think we have more everything in place if we at least will be able just to look at the cardiac biomarkers and echo. I think we will got a lot of information out of it.
And in case we have some abnormality in speckle tracking echo or even reduced ejection fraction, what would be treatment strategy for that patient?
It is an interesting question. I think it is a question for future clinical trials, because as I have already mentioned in my presentation, that it is interesting to focus on those who have pre-HF, and basically those patients who recovered from acute COVID might fit to this group of patients, but we still don't know, because the main question is if these changes, what we see, like impaired GLS, if it is recovered over time, maybe it just is accidental findings. Because as we know, for example, if you look at those who had influenza, we also may see residual cardiovascular abnormalities and elevated cardiac biomarkers, but we didn't look closely at those patients who recovered from influenza. So I think we still need a little bit more time to see new data, or maybe to do a trial and get more data on the myocardial recovery over the time, and then we can classify those and discuss the potential intervention. So,
I have a question. If we don't have a treatment for people with some abnormalities by echo, is it useful to make screening, speckle tracking, etc., in clinical practice? Of course, in the study, it's interesting to investigate how many abnormalities is, or maybe to launch some new study with some therapy, randomized study or with some therapy in patients after COVID. But is it useful to do it in clinical practice, or just work with patients who will come to us with some symptoms?
Yes, I think so. I think it's a very useful imaging biomarker, and we have a lot of data supporting the prognostical significance of GLS. And what we see in the recent heart failure guidelines, when we are speaking about pre-heart failure, we see that among all structural abnormalities, we also can see LV strain, which is considered as a sign of myocardial disease, when we can say it is pre-HF. So I think that yes, it is worth looking at it. And also it depends on what type of patient you are looking at, because we know that it is very significant for patient with cancer. We know that GLS is a marker when we decide if we need to treat them, if the patient needs cardioprotection or not. It's one of the parameters.
Yes, of course. In cancer, we have studies, we have the data, we understand what we're doing. I mean, in patients with COVID, not with cancer.
Well, but we don't know yet. But if we want to answer the question, if it is pre-HF, I think we need to use everything we have. But if you ask, if it guides us on a decision if you should treat them or not, what ACC statement says that we only treat those who have mildly reduced LV ejection fraction. So we use beta blockers or ACE inhibitors. Actually, it's like a conventional approach what we do in patients with heart failure. So till now, there is no any trials, any results on it. So we'll see. Thank you.
Okay, thank you.
Maybe just one comment, because we usually talk about ejection fraction or deformation or strain of left ventricular, but we do not mention about left atrial. But I think many experts signify that enlargement of left atrial perhaps is the most sensitive and specific changes on echo in terms of prediction of heart failure development.
Yes,
so
true.
Maybe usual clinical practice for clinicians, when they don't have specific, like super comprehensive echocardiography, they could use just simple marker of left atrial enlargement and think about potential heart failure diseases and treatment, more intensified treatment of cardiovascular risk.
Yes,
Thank you very much for your talk, Anastasia.
Thank you. Thank you. And now it's a great pleasure for me to introduce the next speaker. It's Dr. Ilya Giverts from the Moscow City Clinical Hospital. He is a specialist in heart failure and cardiac rehabilitation. And he is going to talk us about telemedicine and heart failure. Ilya, please.
Dear colleagues, thanks for the invitation. Can you hear me? Can you see me well?
Yes.
Okay. So let me introduce myself. My name is Ilya Giverts, and in the next 15 minutes, I will try to give a brief overview of telemedicine, its pros and cons, and potential clinical application in heart failure. I have no disclosures. So broadly defined, telemedicine is the use of advanced communication technologies for the purposes of making diagnosis, distant monitoring, conducting research, transferring patients' data, and improving disease management in remote areas. Despite certain skepticism, in the last few years, it became an extremely hot topic, especially in the setting of the ongoing COVID-19 pandemic, putting an enormous stress on healthcare systems and patients worldwide, and creating serious limitations for the visits to medical facilities. It must be noted that telemedicine is just considered just one of the aspects of modern e-health technologies, and we try to look at this issue from a more general perspective. We may identify three main innovative trends in modern healthcare. The first one is digital health, that encompasses a bunch of invasive, non-invasive, and smartphone-connected mobile devices, so-called mHealth, enabling monitoring of multiple health parameters. The second trend is big data, including artificial intelligence and machine learning, providing aggregation and analysis of large amounts of information for better clinical decision-making and predicting outcomes. And the second trend is precision health, or so-called p-health, that initially was considered mostly a genomic area, but now incorporates a huger amount of fancy omic tools like metabolomics, proteomics, and microbiomics. Hopefully, that's how a promising future looks like, but let's get back to telemedicine. There are two basic scenarios with telemedicine and heart failure. The first one implies the use of technology that enables an exchange of medical data between different healthcare providers, so-called doc-to-doc telemedicine. It is intended that diagnostic information comprising mostly imaging data like ECGs or echo findings may be transferred by nurses or GPs to more experienced colleagues for verification. Thus, this scenario is suitable for screening and follow-up of heart failure patients in rural areas or in case of sparse access to specialized heart failure centers. The second scenario, so-called doctor-patient telemedicine, entails a connection between patients and cardiologists using the virtual contact through the messengers or through the electronic devices that transfers patients' data to the healthcare provider. The second scenario is more common, and we will particularly discuss this type of interaction. There is a huge number of remote monitoring technologies for heart failure that can be roughly divided into non-invasive and invasive devices for measuring vital signs, lung congestion, and hemodynamics. What is the rationale for remote monitoring in heart failure? If we look at the traditional paradigm for the management of heart failure, it is mostly reactive. By the time the patient has obvious clinical signs of congestion, it is often too late for conservative treatment and the patient has to be admitted to the hospital. But signs and symptoms are just the tip of the congestion iceberg in heart failure. And we all know from the previous studies that hemodynamic congestion may increase gradually for days and sometimes even weeks prior to heart failure decompensation in both HFrEF and HFpEF, potentially providing a therapeutic window for intervention. And the question is, can we change the management to a more proactive paradigm to prevent acute heart failure events? Can we effectively use this time frame to benefit the patient? Unfortunately, identifying pressure volume status by conventional physical exam, changes in vital signs of body weight, and even radiographic data is frequently ineffective in preventing heart failure hospitalizations because these events manifest late during decompensation and relatively unreliable. In daily practice, we ask our patients to take an extra dose of diuretic if they have a 2 kilo weight gain in 2-3 days, but the graphically the sensitivity of weight gain for determining heart failure exacerbation is very poor. If the patient gains weight, it is pretty specific that he or she is volume overloaded, but failure to gain weight does not necessarily mean that the patient is doing well. Probably that's one of the reasons that the vast majority of the trials investigating remote assessments of usual care parameters has not demonstrated uniform evidence of benefit. Other possible causes that remote monitoring of vital signs may be not sufficient to improve outcomes are low patient adherence to data transmission and the lack of clear algorithm how to interpret data received and respond to alerts. If you have an appropriate algorithm designed to be a true holistic approach with a large team of healthcare workers that are able to provide over 1 million interventions within one protocol, like it was in the TEAM-HF2 trial, you can finally get a reduction in mortality with remote monitoring. Lung congestion can be also measured by thoracic impedance that relies on the principle that electricity travels better through fluid than through bone, tissue, or air, and thus less resistance or impedance may indicate lung congestion. Cardiovascular implantable electronic devices, including CRTs and ICDs, can measure thoracic impedance across the generator of the chest wall to electrical leads in the heart. One thing is promising, the remote monitoring of heart failure patients with implantable devices has not been generally proven to reduce morbidity or mortality. In addition to lack of benefit, one study demonstrated even potential harm caused by inappropriate alerts leading to extra outpatient visits and unnecessary hospitalizations. However, the devil is again in the details. And if we look at the recent sub-analysis of the Optilink study, only 1/3 of all transmitted fluid index threshold crossing alerts were responded adequately, and instead, appropriate handling of alerts independently reduced the risk of primary endpoint. Lung congestion can be also evaluated by remote dielectric sensing. In contrast to thoracic impedance, REDS monitoring requires a wearable, non-invasive device. This technology was originally used by the Israel military forces to see through the walls and find survivors in the rubble of the collapsed buildings, and subsequently was adapted for medical use. Just take 45 seconds to get REDS measurements of the lung fluid content, and it may be performed anywhere. I'm going to walk you through some evidence that exists out there, and this is a randomized study looking at the use of REDS technology at the time of discharge in a cohort of heart failure patients who were considered to be clinically euvolemic and ready for discharge. However, 33% of these patients were found to be still wet according to REDS measurements, and patients from the treatment arm with REDS indices higher than 39% were kept at the hospital for a while and treated with extra doses of diuretics, leading to additional loss in weight and congestion. And those in the control group who were congested at the time of discharge had higher readmission rates. Now, the SMILE trial was a prospective randomized study of the longitudinal use of REDS technology in both HFrEF and HFpEF, and it was a neutral trial. There was no significant benefit concerning the rate of readmissions over a 9-month period. However, it turned out that in 15-20% of observations, either patient has stopped transmitting information or there was no adequate response from the healthcare provider. When you make adjustments for that, you can see a reduction in readmissions almost by half. So obviously, a wearable device may result in lower adherence, and that brings us to the point that more sophisticated implantable monitors seem more effective in terms of compliance, and furthermore allow early detection of lung congestion through the direct measurements of cardiac pressures. There are two PA pressure implantable monitors in the market. The most well-known and still the only FDA-approved called CardioMEMS, and the relatively new one called Cordella that was tested in the first-in-human Sirona trial and is now under investigation. CardioMEMS was the first sensor device that was able to demonstrate improvements in outcomes in the pivotal Champion trial. That was confirmed by the data in the post-approval period. We can see that the control group, after the physicians were unblinded, demonstrated an almost 50% reduction in heart failure hospitalizations, and even more, patients that were treated according to hemodynamic guided management had a significant reduction in all-cause mortality rates comparable to the effect of ARNIs in the Paradigm trial. If we look at the real-life post-approval data, we can see marked reduction in heart failure hospitalizations that was maintained along all ejection fraction groups. The most recent trial with CardioMEMS was the guided CHEF trial, actually showing the borderline results. However, this trial was started just before the COVID-19 pandemic, resulting by itself in a lower rate of heart failure hospitalizations. And if we adjust results to the pre-COVID data, we may see the benefit that we've seen in trials. So even without data from guided CHEF trial, this meta-analysis of two strategies of remote monitoring using implantable devices and thoracic impedance demonstrated a 25% reduction in heart failure hospitalizations utilizing invasive cardiac pressures. An alternative to PA pressure monitoring is left atrial pressure monitoring. LA pressure transducers are placed percutaneously via transeptal puncture within the intraatrial septum. The most well-known devices are HeartPod and the new one, BLAP. Laptop HF trial with HeartPod device was terminated early, despite reduction in heart failure hospitalizations due to a number of implant-related complications. Preliminary data for wireless battery-free VLAP device have demonstrated safety and feasibility irrespective of ejection fraction in the Vector HF trial, and this technology will continue to be pursued. Summarizing the evidence, the most recent guidelines give remote monitoring heart failure a 2B class recommendation. We have some other perspective technologies like artificial intelligence used for voice recognition of congestion and also breath metabolomics using exhaled gas analysis. Here is a nice study performed by my friend, Dr. Alexandra Bykova from Sechenov University, demonstrating high concentrations of acetone in both FREF and HFpEF patients in comparison to the control group with arterial hypertension. The COVID-19 crisis created serious challenges to healthcare delivery, facilitating transition to telehealth services. And this study using propensity matching demonstrated no difference in clinical outcomes between virtual visits and in-person visits for heart failure patients. This data strongly suggests that telehealth outpatient visits in patients with heart failure can be safely incorporated into clinical practice. Telehealth technologies applied for home-based cardiac rehab is also a promising direction. However, the existing data that support home-based training quite restricted in terms of patient selection and have largely relied on staffing and equipment models that are not really easy applicable and not necessarily less expensive than sensor-based programs. The most recent and largest TELERAC HF study demonstrated that despite improvements in functional capacity and quality of life, after 2 weeks of home-based training, the program showed no improvement in clinical outcomes. So in conclusion, telemedicine heart failure is evolving fast, but it lacks solid evidence and cost effectiveness despite certain positive trials. The CardioMEMS device seems to be the strongest one from the evidence point of view. Virtual visits are feasible and safe for heart failure patients. home-based training may be applied in selected low to moderate risk patients to overcome the barriers for cardiac rehab programs. Technology must be available, effective, and user-friendly for successful implementation and for the future. Sufficiently powered trials of both monitoring and intervention are urgently needed. Thank you for your attention.
Thank you very much, Ilya. And maybe short question to you, because the topic is so interesting, so promising. But my main question always was, okay, we can identify congestion a bit earlier, but what should we do with that information? Should we just increase doses of diuretics? Or my personal opinion is to try to titrate optimal medical therapy. What is your opinion? Or maybe even stop diuretics or add nitrates. There are some different views on this.
Yeah, thank you for the question. So basically, what we know from the, for example, CardioMEMS trials, they were successful mostly, I think, because the doctors reacted to the data they've received through the monitor, and we know that both dry and wet condition of the patient is bad for heart failure. So I think, yeah, maybe it's not about only diuretics, but probably as well more aggressive titration of guided directed medical therapy, and that's the key to success.
Thank you. Yeah.
I have a question. Why we need something additional to uptitrate guidance-based therapy? We just can uptitrate it without additional information.
Yeah, that's a perfect question. Well, probably this data may give you a little push, because sometimes doctors are really afraid to titrate guided directed medical therapy for low blood pressure, or for the symptoms that feel the patient by themselves. And probably if you see the deterioration, some unstable situation, that may give you more arguments to be more aggressive. That's my perspective.
Okay, thanks. I have one more question. If we speak about some tablets, everything is clear. So we use the tablets, make randomized trial, and see the result, and then can use them or not use. If we check in randomized trial telemedicine, the important factor how healthcare is organized in the region when we made the study. For example, in England, there is heart failure nurses, and the patient, it doesn't matter in the study, this patient or not, can call this nurse and ask some question. And in this situation, it's harder to show that additional telemedicines will help, because the patient has somebody who could call. For example, in some countries, there is no such nurses, and patient is alone with his disease. Do you think that we should have different randomized trials in different countries, because one approach could not work in different health services?
Yes, sure. I strongly agree with that. And the healthcare system and the insurance, and the co-payments and how it's covered, it's all differs in different countries. We don't have nurses like specialized in heart failure follow-up, and so of course we need one size doesn't fit all. Yeah, sure.
Okay, thank you. And we will go further. The next speaker will be Rustamova Yasmin from Baku, and her talk was evaluating of myocardial viability in heart failure.
I think Ilya should stop sharing his screen.
Yeah, sure.
Can you see me? Can you hear me?
Yes.
Yes, thank you very much for joining us today. We are happy to see you.
I'm happy to see you as well. I'm sorry. Okay. Just let me know whether you can see my presentation or not.
Yes.
Okay, very good. So you can see it good. It's big enough so you can see it. So, good evening and thanks again. I'm sorry I'm kind of late a little bit today, but I'm happy to see all my Russian, not only colleagues, but friends all together and happy to be with you. Thank you for inviting me. Today, I'm going to talk about the evaluating of myocardial viability in heart failure patients, and this is the topic that I'm doing deal with every day, and I'm happy to talk about this. So what are the main points when we talk about the heart failure patient? So why do we do the REVASC? Do we need to do the REVASC actually in heart failure patient or not? Of course, the topic is about the heart failure with reduced ejection fraction. So what are our goals? How do we evaluate the viability, and is the prognosis is better when the myocardium is viable? So why do we do REVASC? So first of all, of course, we want to reduce the symptoms of heart failure, and if there is an angina pectoris, also of ischemic heart disease, and we also want to see how it will be the effect on prognosis. Of course, to reduce the mortality and morbidity and the heart failure hospitalization of patients. But we all know when we talk about the heart failure patient and the multiple disease, we always talk about the very high risk of ischemic cardiomyopathy patients. And that's why we have to always think about the risk and benefit balance. So what we are actually expecting, we are expecting that the resting left ventricle ejection fraction will go up. So if there is ischemia, so we are going to get rid of this ischemia, and also we are going to effect on ventricular remodeling and also diastolic function. Also, we want to prevent the ventricular arrhythmias, and as a result, we are going to reduce the symptoms of congestive heart failure. So what are our physiological goals when we talk about the heart failure? We talk about the dysfunctional myocardium, but the point is that not always dysfunctional myocardium is about the scar. When we have the long-lasting ischemia, sometimes we can have also the viable, the dysfunctional myocardium could be hibernating, and as a result, we are going to have the dysfunction of myocardium, but which is viable. So our goal is actually to reverse the hypocontractility that persists despite the restoration of blood flow. So, and what we want to make when we have the hibernating myocardium, we want to restore the blood flow, and as an effect, we are going to have the high contractility, the normal contractility. So what is the clinical scenario? So we have the coronary artery disease. Sometimes patients even don't have any history of myocardial infarction, but we can see the patient with heart failure and reduced ejection fraction. Sometimes we can see if there is an angina or not. But now we know that the typical symptoms of angina pectoris is only in 10 and 50% of patients, and especially when the patient is with a multiple disease and with when the patient is diabetic patients. Of course, we don't have this typical clinical scenario like a chest pain, and we are going to have symptoms, the shortness of breath, and we know that we never know whether the shortness of breath is because of equivalent of a stenocardia or angina pectoris, or is the shortness of breath is because of congestive heart failure. So what we have to do with these patients, to be honest, the first of all, we are going to test whether this severe left ventricle dysfunction or whether this myocardial dysfunction is because of the scar, which is because of severe coronary artery disease, or we had a long-lasting ischemia, and as a result, we have the viable myocardium. So, how can we assess the viability of myocardium? We have a dobutamine stress echo, we have the nuclear methods, and we also have cardiac MRI. Me personally, I do perform dobutamine stress echo and cardiac MRI, and of course, in this topic, I'm kind of biased because I present the methods which I do every day. This is about the pathophysiological goals in ischemic heart failure patient, as you can see here. Just a second, and you can see here. So we have the subendocardial scarring. We have the disturbance just inside the cells, and we can see also here like late enhancement in cardiac MRI. The point of late enhancement, like in these patients, is that we can say that here is, which is white, is the late gadolinium enhancement because of the subendocardial scar, but it looks like it's 50% or maybe less. But the point is that everything depends on the cardiac remodeling, because here we have, for example, as you can see, I don't know whether you can see it, I try to show you. Okay, here you can see that the lateral wall is thick enough. So in case if we have the extension of myocardial scar about less than 50% in the wall, which is not actually too much in the negative remodeling, then it is okay. But even in this case, we have the enough thin. It's about maybe 6 or 7 millimeters. I didn't measure it, but I can see it. It's about 7 millimeters. And even here, if you have the extension of myocardial scar less than 50%, it will maybe affect not bad on the prognosis of patient, but in the point of view of remodeling and in the point of view of restoring of left ventricle ejection fraction, I'm kind of skeptic because it needs time. So which are the imaging modalities that we can use is the echo. What we can see in echo. Of course, we can see in echo, in normal echo, when we don't use the dobutamine, we can see only how is the contractility of left ventricle ejection fraction. And of course, we need to use the low dose of dobutamine to see if there is a contractile reserve of this dysfunctional segments. And then we can use also the SPECT and PET. I'm not very good in nuclear medicine, but I know that we are talking about the metabolic and metabolism match in the myocardial cells. We can also use the CMR, of course, and the CMR is actually very good because from one point we can assess if there is a perfusion defect on CMR, so we can see if there is ischemia or not. From the other part, we can also use the dobutamine stress echo in CMR, but I actually don't like it too much. But we also use it in patients with a severe kidney dysfunction when we really can't use the contrast medium. And which is really very good is to see if there is a late enhancement. So the point with the late enhancement is only the problem when we have the gray zone. So when we have, of course, the extension of the scar of more than 75% of the thickness of myocardial wall, of course, there's no question that there's no viable myocardium which is not going to restore after the revasc. But the point is when it is the extension of myocardial scar is less than 50% or 25%, and when the wall of myocardial the thickness of myocardial wall is good enough, it's about 10 or 12 millimeters. So of course you can give a good prognosis that this myocardial is viable and will it has contractible reverse and it will be okay after the revasc. The problem is only when the extension of myocardial scar is about 50%, and in that cases we can also use the dobutamine even in CMR. About echo, echo is very good, but I'm going to share with you one patient with a very severe left ventricle dysfunction and not good ventricle walls which were not too much thick. But sometimes doing echo, we also can see even without any dobutamine, we can see that if the wall, we always learned it, like if the wall is akinetic, then you can just prognose it that will not reverse and be sure that it is scar. But it is not like that. It's really not like that, and there is no actually any connections, associations between the akinetic or hypokinetic and also the reverse of myocardium. I don't speak about the PET and SPECT as I'm not a specialist of that, but cardiac MRI is really very good method. And when we talk about the diagnostic significance of different methods in the assessment of dysfunctional myocardium, you can see that was 10 years ago, saying that the specificity is very, very high, especially in cardiac MRI. In cardiac MRI, it is I would say it is very not good. Let's say not very good in a nuclear patient, and even I don't like. I will be happy to talk with a nuclear specialist, but I really don't like this method because they takes too much time. And for patient which is in heart failure, it is really very difficult to spend so long time there. So of course they could say that cardiac MRI also takes time. Yes, it takes time. It's about 40 to 50 minutes in one patient, but when you have the more than 76% of specificity, I think it's very, very good method. Talking about the PET and versus MRI, we have several articles regarding that, and we can say that the lower the ejection fraction, the better cardiac MR is. So that's the question. Of course, but why should we see whether there is, for example, an extensional scar in patient which is left ventricle ejection fraction is preserved? So it's clear when the patient has a preserved ejection fraction and even multiple vessel disease, it should be revasc. I think there's no question about that. The question is only in patient with a reduced ejection fraction. But anyway, this article shows that the lower the ejection fraction is, the more accuracy, the percentage of accuracy of cardiac MRI is better. And sorry, this is the very nice. I like this article very nice. It comes from Brasilia and also shows regarding the extension of myocardial scar. So talking about the extension and the transmurality, we have to understand that there is two different approaches. One, we can have the very transmural infarction, like here, for example, when the percentage of the thickness is more than 50% or more than 50 and 75%. This is the transmurality. And we also can have the very extensive scar. And that is very important because when I do the report of coronary artery disease and heart failure every day, and the point is that I try always to write down which coronary artery is actually affected. So this is very important because when we have the multiple disease, we have shown to our cardiologists, to invasive cardiologists or surgeries, which coronary artery should be revascularized. And this is nothing to do with the transmurality. It's all about the extension. Also, of course, we go by the classical report, like Bulleye in ECHO. We use the 17 segment models, and you can see here if we have an anterior and anteroseptal. Of course, we talk about the LAD, and when we talk about the lateral wall, it's all about the CX, and when we talk about the inferior wall, we talk about the RCA. This is the classical view, and also we talk about the transmurality. We also make the prognosis whether we want to revascularize the patient because of prognosis. It means that sometimes the revascularization cannot affect to the left ventricle ejection fraction. It means that the patient can still have the symptoms and the signs of heart failure, but from the point of view of prognosis, the revasc will be very good for this patient because even this small area, even if this small area will be revasc, it will be very good for the patient. So this is about that. So what is the algorithm? The algorithm is what I talked about just before. So when we talk about the transmurality, when we have the transmural scar, which is more than 75%, it means that that zone is unfortunately not viable, and there's no absolutely meaning of revascularize that zone. And when the transmurality is below 50%, it means that the very high probability that this myocardium is viable and the contractility will be reversed after the revascularization. So, and the problem is always with the 50% with the gray zone patient, and we can use the low dose of the butamine. I want to share with you, this is the woman with 66 years old, 3 vessels disease, and with ejection fraction of 22. From here, I hope that you can see here on the left side, you can see it moves. Okay, just on the eye, we can see the dilated left ventricle. I personally seen this patient in the polyclinic, and I seen her echo. I wrote that she has a left ventricle ejection fraction of 25. 22 is from MRI. So she has a mild mitral regurgitation. We can see here from here. And to be honest, I was not very positive thinking about this patient. Patient has the symptoms of heart failure. She symptoms of congestive heart failure, shortness of breath, etc. No pain, and it's clear why. But look, after giving the contrast media, we cannot see the contrast media absolutely. So she was a 3-vessel disease patient with the chronic occlusions, and she has a very long-lasting ischemia, and that's why this myocardium is actually hibernating myocardium. There is no scar, and so you can see here there is a subendocardial scar in the anteroseptal and the septal wall. This is the only mid. This is 2 chamber view, and this is the short axis view, and I showed only the mid part. When you can see here the subendocardial, so it's low and below 50%, and it means that the mostly myocardium is actually we said that it was viable, and we asked the surgeon to make the bypass surgery. So she went to bypass surgery. Just 1 year later, the ejection fraction was 48. So we did perform again an MRI. As you can see, I would never believe that that is the same left ventricle. And we can see, of course, the MRI is not the best choice for assessing the mitral regurgitation, but even here we can see that we have only mild regurgitation here and the positive remodeling of left ventricle. So this is the 4-chamber view, this is the 2-chamber view, and this is the 3-chamber view. So is the viability is the way to improve the prognosis? We still don't know, because in the guidelines we have only one randomized trial, which is STITCH trial, and which is not actually very positive regarding the viability. So I actually have many things to say about the STITCH trial, because yes, I know it's the only one randomized trials, but to be honest, for today, this trial is a little bit old. And we know that we have now the ongoing trials on left ventricle ejection, on the reduced on the viability and reduced ejection fraction ongoing trials. We are waiting for this. But you know that in STITCH trial they didn't use any MRI, only SPECT and dobutamine stress echo, and that's actually bad. But this is all that we have. So I think that the STITCH part of viability trial, this part has more questions than answers, because it's always open. But now, of course, with these ongoing trials, we are going we are waiting for the ongoing trials. So that was actually the old guidelines. That's why I don't want to stay on that. But yes, I know that I'm very biased on cardiac MRI, saying that it's the best method to see whether there is a scar or not. But in the guidelines, we have regarding the guidelines, we use all the methods. So endobutamine and SPECT and MRI, all these methods are good enough. And to conclude, I want to say that, first of all, if the patient has the reduced ejection fraction of left ventricle, we have to select good patient for revasc. And we have to have a very good heart team with a very good invasive approach, because sometimes even when we have the 3-vessel disease, and then as I said before, even 2 or 3 arteries, maybe sometimes no need to revasc them because there's no viable myocardium in that zone. Sometimes in patients that we think must go maybe in bypass surgery, could be revascularized using the invasive methods, but without opening the heart. And I want to say that without imaging doctors, I think that cardiologists will be as blind as a mole. And I want to thank you for the collaboration and for your attention. Thank you very much.
Thank you very much, Yasmin, for your excellent presentation. Now we can move on to our discussion, and maybe a short question to you, to your clinical practice and algorithm that you use, because we previously also have learned from another speaker that really there is very low proportion of patients who underwent invasive coronary angiography, even in case of reduced ejection fractions. So what is your clinical algorithm if you see de novo FH heart failure with reduced ejection fraction? What do you use as a first step in investigation of etiology and maybe treatment strategy? Invasive coronary angiography or MRI? And
Thank you for your question. So first of all, if we see the patient with HFrEF, de novo HFrEF is stabilized. To be honest, we do perform both methods. Whether invasive angiography or cardiac MRI, we never choose. We do perform both methods. It depends. Sometimes we do first angiography and then cardiac MRI. Sometimes it depends on the organization when we don't have time for an invasive lab. So we do send the patient to cardiac MRI, and after that we do perform the invasive. Maybe by doing the cardiac MRI, it is maybe better because already know the diagnosis, whether it is ischemic or not. And then after the angiography, we make a decision, should we revascularize the patient or not? So, but we do perform both methods.
And maybe just another also short question regarding the impressive clinical case which you have shown us with really improved ejection fraction. What was the medical therapy in this patient? So was it like Fantastic Four or?
No, it was not. I told you, this is not the new clinical case. So the only new, so we didn't use any SGLT2 inhibitors, etc. So the only new method that we used it was ARNI, EMRA, beta blockers. So classical, what do you use as well? So the same. No SGLT2 because it was a little bit late clinical case. It was about 2019. So at that period, we didn't use SGLT2 as much as we use it now. So I think it's all about the Revasc. It's not about ARNI. So ARNI is good, of course. We don't talk about that. But in that case, it's all about the Revasc, I think.
Great. Thank you so much. Dear colleagues, we don't have questions from the audience online, but maybe some of you have questions as well.
May I ask one?
Yes, of course.
I was wondering, Yasmin, how do you think, is it any place for cardiac CT for assessment the viability? Maybe because we saw some attempt to make this assessment. What do you think about it?
To be honest, it could be. Why not? And also because CT is very short, and also maybe for the patient with reduced ejection fraction from one point, it will be better to use the CT than MRI. But to be honest, as the temporal resolution and also that the accuracy of cardiac MRI, I think will be not, so CT is not better than an MRI. And if we do perform the coronary CT to the patient, of course, we can also scan the left ventricle to see whether there is a scar or not. But I would not use that method to make a decision about the Revasc. So from the point of view of coronary artery, I would agree with you. But from the point of view of extension of scar, I'm not, to be honest, I don't think so. But this is my personal view. It doesn't mean that it is like that.
Thank you.
I have some questions to Ilya. A very important topic, especially in pandemic. Thanks for presentations. And are these technologies available in Russia? And which is this? If yes, is used in your clinic and other maybe clinics in Russia?
So basically, we don't have any implantable devices in our clinic, and I think the cost effectiveness of, for example, CardioMEMS in the Russian reality may be debated. In US, the cost effectiveness of CardioMEMS is related to the high cost of the hospitalization, which is not the thing that we have in Russia. So basically, I really perform the virtual visits with my patients, and I have a lot of talks on the phone and through the messengers. And I think if we're talking about, well, more or less stable patients, it's a good strategy for follow-up. And also I'm involved in cardiac rehab. Mostly it is center-based. And there are some advantages of center-based rehab in comparison to home-based training. And one of the advantages from my point of view is that center-based rehab allow to interact closely with the patient for a pretty long periods of time, and this allow to really obfuscate the guided medical therapy. and you have an opportunity for proper adjustment of training regimen, which is really sometimes not feasible if we're talking.
Thank you very much.
You're
and I have
thank you.
And I have a question to Yuri for my topic. Yuri, can you tell us epidemiological situation in Russia, maybe in other centers, in other parts of Russian Federation?
Sorry, what do you mean exactly?
Epidemiologic heart failure prevalence in Russian Federation. I know you participate in registers.
Interesting thing and really interesting question. And there is a problem in general with epidemiology of heart failure. So, for example, if we need to find how many we have atrial hypertension, we can go for the houses, measure blood pressure, and ask patients who use and don't use hypertension medication. And this is why we can more or less precisely say that the number of atrial fibrillation is this. It's more complicated with heart failure because it's hard to go for house to house with echo machine. Also, if we even do this, the one thing, if you go to the home and say, okay, I can quickly measure your blood pressure. And the other thing, if you say for patient, oh, I need to do echo, it's take 30 minutes. It's different. And this is why it's to do any epidemiology study in heart failure is very hard. There is some international study, and there is a Russian study, POHA. In the POHA, the people ask for symptoms and for the fact if they have cardiovascular diseases. But there wasn't the echo wasn't done in POHA. This is why it's hard for the study say about heart failure prevalence. There is another study, epidemiological study, which was also made in Russia. It was a joint project with Norway and UK, and they came to houses and then asked patients. They made it into cities, Arkhangelsk and Novosibirsk, and they. After the visit, they asked a patient to go to the hospital for heart failure, for echo. Echo was part of the study. It was free for patients, but around from 50 to 70% of patients, depends on the town, came to the hospital visit. So we haven't the full information, and this is why the person, if we take number from epoch, it's 8%, but it's question, is it, what will be the check echo, with check BNP, etc. And interestingly, we look epidemiology, we found that the person with heart failure varies in different countries and varies from less than 1% in some places to 4% in Australia. And of course, the one reason for this difference is that population, the average age in different populations differ. But the next thing is that it depends on how we do the study. Are we do echo or not? We do the echo. Are we do BNP or not, etc. And also interesting, it's when we take just several towns, for example, there's a great study in Norway, in Tromsø. It's a small town in the north part of Norway, and they are doing cross-sectional studies for a lot of years. So they make one cross-sectional study, then another, and they have very good data. But if you look yes Atlas, you wouldn't find a prevalence of heart failure in Norway. Why? they have TROMSA. And they answer this. Why? They say, yes, we have great TROMSA study, but the TROMSA study show what's happening in TROMSA, not what's happening in whole Norway. And this one town could be different from the whole country.
Thanks very much.
Do we have other questions?
I think we don't have other questions, and we could close our really great session and say again many thanks to our colleagues who could join us today and be with us. Yuri, maybe I will turn to you to close the session in front of our offline or in-person audience. Thank you.
Yes, Harfeli is a really interesting topic, and we speak about interesting things like heart failure and ischemic heart disease and about variability. And of course, we are waiting for new studies about PCI in heart failure because it's very interesting. Should we revascularize more patients with heart failure or less? Because of course, we would revascularize patients who had angina, but should we revascularize a patient not have angina? It's questionable, and we will get this data in the future. So it's quite interesting, the topic about COVID and heart failure. Hopefully, a recent study shows that it's not so bad as we thought 2 years ago. So it's not, it's, and there will be some heart failure after COVID, but it's not be like tornado of heart failure cases, fortunately. And also it's very interesting discussion about universal definition of heart failure. This is the first universal definition of heart failure. And it's, I hope it will be a good tradition. There's several, there's in myocardial infarction, they have even several editions of this classification, and they improve it from 1 year to another, and hope the same will be with heart failure. And also, of course, telemedicine in heart failure is very important topic. It was important before COVID. It's become important even more now, and also it will be even more important in the future because people who are young, who always with their devices, they will become older. They will, unfortunately, some of them got heart failure, and probably they would like to get a lot of their health service in virtual. So this is why it's important in these cases and to learn how we really could improve patient prognosis. Any other comments? I think we should finish because there is the time. Thank you for participation.
Thank you.
Thank you very much.
Thank you. Bye.
Very much. Yes, bye-bye.
Thank you. Bye.
Thank you, Henny Khan.